Hello, good evening. Welcome back to our webinar paper of the month. And first of all, I would like to wish you all a happy new year. There are still 54 days to go, but I'm sure 2023 will be hopefully a much better year than last year. And because we have still the paper of the month as a webinar, and it's a pleasure to chair this session together with my friend Peter Siersema. I think everybody who has visited this webinar knows us meanwhile. It's a great pleasure to have again invited two outstanding teams for two papers. And in the next 60 minutes, we will present, or the authors will present their papers, and we have also top experts who will comment this paper. And the first paper I would like to introduce is a paper from Hong Kong, and the group of Professor Shannon and Professor Philip Chiu. They present the over-the-scope clip in GI bleeding. And as you may know, we had last year also a paper from Los Angeles, and this paper will be commented today by Professor Schmidt, who also published on this topic. So in the meantime, we have 3 papers on this topic, and I'm happy that we have now experts who present us with this data. And let's start with Professor Chan. Thank you.
So good evening, my name is Shannon, and I'm an assistant professor working in the Department of Surgery from the Chinese University of Hong Kong. So today I have Professor Philip Chiu with me, and we are going to present this newly published RCT that we have performed in the past years. So the topic is use of the over-the-scope clip versus standard therapy for prevention of rebleeding in large peptic ulcers, defined as size more than or equal to 1.5 centimeter. An open-labeled, multi-center international randomized control trial. So these are all my collaborators from all over the world. So thanks to them for the completion of the study. This study was published in GUT in 2022, and this study was supported by the Hong Kong Government Research Fund. So rebleeding occurs in 15 to 20% of high-risk peptic ulcers, and recently, meaning at the time of the design of this trial, OTSC was used as a primary hemostasis just then. So the aim at that time was to compare the efficacy of OTSC to standard therapy in primary treatment of patients with peptic ulcer bleeding that are of high risk of rebleeding. So this was a prospective, open-labeled, multi-center, randomized controlled trial, and we recruited patients to receive OTSC or standard therapy by randomization. And these are all the centers that were involved in this study. So we included all patients with a Forest 1A, 1B ulcers or a 2A ulcers. So, and the ulcer size has to be more than or equal to 1.5 centimeter. We excluded all patients who are below 18 years of age, peptic ulcer with concomitant perforation, tumor and visceral bleeding, patients who are pregnant or lactating, moribund patients who with a life expectancy of less than 30 days. So the primary endpoint of this study was clinical rebleeding within 30 days. Secondary endpoints include death from all causes within 30 days, transfusion requirement within 30 days, hospital stay, ICU admission, failure of achieving primary hemostasis, further interventions such as repeat endoscopy, surgery, or transarterial embolization. So the sample size calculation was based on a RCT that was performed by Professor James Lau. So in this RCT, he randomized patients to high-risk peptic ulcer patients to either to receive standard therapy only or together with prophylactic transarterial embolization. And in this study, the cumulative probability of further bleeding in these large ulcers of more than 1.5 centimeter without prophylactic angiographic embolization was 23.3%. As you can see here, here in this cover marker. So we assumed that OTSC would reduce the rebleeding rate from 23% to 5%, and using a two-sided log rank test with 5% significance level, 100 patients is required to achieve 80% power. So crossover was allowed in this study. So meaning that patients who received standard therapy, and if they had failed primary hemostasis, which was defined as persistent bleeding after application of the randomized treatment, that is, if it's standard therapy or OTSC. So for OTSC, after application of OTSC, if there was persistent bleeding, then it was defined as a failed primary hemostasis, and the endoscopist is allowed to cross over to the standard arm. Consents were taken from all patients with clinical suspicion for upper GI bleed and indicated for OGD. So once the endoscopist confirms the eligibility of the recruitment, meaning a Forest 1A, B, 2A ulcer with a size of more than or equal to 1.5 centimeter, the patient was randomized, and a randomization was taking place with an online randomization form in the form of a computer-generated randomized sequence in blocks of 10. So endoscopists cannot be blinded due to the different endoscopic therapy, and a patient does not really have to be blinded since it does not affect the clinical outcome of clinical rebleeding. And all these primary and secondary outcomes were actually assessed by independent assessors and not the endoscopist, him or herself. So these are the results. So the basic demographic data were very similar in both groups. There were 50 patients in each group, similar age, similar gender, similar forest classification, similar size of ulcer, and similar location. And the study actually took 3 years and 3 months to complete. So this is the study flow chart. So 50 patients was randomized to the standard arm. 48 of the patient had successful primary hemostasis, and in this group, the rebleeding rate was a 9 out of 48, and the rebleeding rate was 18.75%. 2 of them failed and was crossed over to OTSC, and there was no rebleeding, leading to an overall rebleeding rate of 18%. For OTSC, only 46 had successful primary hemostasis. Within them, 2 had rebleeding. The 4 patients who had failed primary hemostasis, they were crossed over to standard therapy. 1 of them had prophylactic TAE because the endoscopist felt that the bleeding was very insecure. And for that patient, there was no rebleeding. For the 3 patients who did not have prophylactic TAE, they all developed a rebleeding, leading to an overall rebleeding rate of 10%. So based on this, with the intention to treat analysis, it was not significant. So the p-value was 0.25, and if you look at the curves, although you do see that the conventional arm actually seems to look like it had a high rebleeding rate, it was statistically insignificant. So the conclusion for this study was that in the ITT analysis, there was no difference in clinical rebleeding within 30 days between the 2 groups. So in this study, I did not publish a per protocol analysis. And the reason, so you may give me some advice on whether this analysis was correct or not. So for per protocol analysis, you analyze, it's only for RCTs who are allowed crossovers, and you analyze the patient according to the therapy that they received. But in this particular study, the special thing is that for the OTSC group, they were crossover to standard therapy after the OTSC was applied. So it made standard therapy application very difficult. And if you do use this data for per protocol analysis, it would be unfair to the standard therapy group because the OTSC has been applied already. So if a per protocol analysis were to be done, then the endoscopist would have to declare that it was not possible to apply an OTSC and only apply standard therapy. Then in this circumstance, per protocol analysis would make sense. So for all of the 4 failed primary hemostasis, they all had OTSC applied already. And that is why, although the per protocol analysis was positive, I did not publish the per protocol analysis results because it does not it's not logical to do so. So these are the secondary endpoints. So in terms of death from all causes, failure of achieving primary hemostasis, they were similar. Total units of blood transfusion, hospital stay, and ICU admission were also very similar in the two groups. For the OTSC, 3 of the patients had TA transarterial embolization, none had surgery. For the conventional group, 1 of them had required surgery, and they were statistically insignificant between the two groups. So I did try to do a subgroup analysis to see if the location, the use of anticoagulants, or renal failure would make a difference to the outcome. They did not. I tried also to add in technical failure, that is failed primary hemostasis, to see if there was a difference, but it was not. So then the conclusion of this study was that in large bleeding ulcers with size more than or equal to 1.5 centimeter, the routine application of OTSC as primary hemostasis did not decrease clinical rebleeding within 30 days when compared to standard therapy. It remains technically demanding to apply OTSC, and a failure to accurately apply OTSC confers to high rebleeding rate, because all 4 of the technical failure cases in the OTSC group, they were located in the D12 junction. So perhaps at these difficult, this location is actually notoriously difficult for endoscopic hemostasis. So perhaps at these difficult locations, OTSC should not be applied, and that OTSC should only be applied in highly selective cases with endoscopists with experience. So in this study, we included endoscopists who had more than 28 cases experience for OTSC application. So the workflow that we would suggest is that even for these large ulcers with bleeding, we would suggest to go for standard therapy first, and if it fails, then OTSC can be used as a salvage. What would I have done differently? So the initial thought when I planned this study was because of Professor James Al's study, where he tried to add prophylactic TAE to see if the rebleeding decreased. So I thought, maybe OTSC, for TAE is quite a cumbersome procedure. Maybe the use of OTSC would be able to replace the TAE to decrease the rebleeding. But if this was the initial thought, then the therapeutic arm should be standard therapy versus standard therapy plus OTSC, because OTSC would be replacing the prophylactic TAE. So a standard therapy should be applied first, and OTSC is just to secure the bleeding. So if it was done in this way, this study might have been positive. This was one of the very first RCTs that I planned. So now I've learned that I should probably sit down and think through the inclusions and the therapeutic arms better before starting, because once you started, it's difficult to change these therapeutic arms in the middle of the study. And because the inclusion is such a small group of patients, the clinical applicability of this study was actually not great. So perhaps changing the inclusion to like broader group of patients may be more clinically useful. So I welcome any advice from anyone who is present here, so then I can learn and maybe do a better RCT next time. So with this, I would thank you all my collaborators from all around the world who helped in recruiting patients and making this study possible. And also thank you, Gut, for publishing a negative trial. Thank you.
Okay, ladies and gentlemen, welcome. My name is Arthur Schmidt. I'm working in the Robert Bosch Hospital in Stuttgart in Germany, and I would like to thank the ESGE for inviting me to comment on this very interesting study by Chan and colleagues. Those are my competing interests. Now, just to briefly again summarize the study, this was a randomized controlled trial at 6 centers investigating OTSC versus standard therapy as first line for patients with bleeding from peptic ulcers with a size of greater or equal to 1.5 centimeters. And the main study result was that there was no statistically significant difference in the primary outcome, which was overall rebleeding rate within 30 days. So actually, those study results were quite surprising to me because there are 3 previously published randomized controlled trials on OTSC versus standard therapy, also showing a significant benefit of OTSC treatment. This was the very first RCT, which we published in 2018. This study included patients with recurrent peptic ulcer bleeding. So this was a second-line therapy study. And in the study, we could show a highly significant difference in terms of further bleeding for OTSC versus standard treatment. The first study on OTSC first-line treatment was published by Jensen and colleagues from the US. This was a study conducted at 2 centers. They included 53 patients and also were able to show a highly statistically difference in further bleeding for in favor of OTSC versus standard treatment. And then there we have the STING-2 study. This was a very recently published study which was conducted at 9 centers in Germany. We also participated in this trial, and this study included 100 patients with a complete Rockwell score equal to or greater than 7. And also in this study, there was a statistically significant difference in terms of clinical success in favor of OTSC therapy. So why are those study results so different? I think the main inclusion criteria, or the main difference was that the patient population included in those trials were different. As mentioned, the only inclusion criteria in the current study by Chan and colleagues was ulcer size equal to or greater than 1.5 centimeters. Whereas the Jensen study exclusively used clinical parameters, and in the STING-2 study, as mentioned, the main inclusion criteria was complete Rockwell score equal to or greater than 7. And just as a reminder, the Rockwell study was showing that those patients had a risk of rebleeding of greater than 40%. There were other quite important differences in the study by Chan and colleagues. We unfortunately do not have in the paper information about the percentage of patients with hemodynamic unstable situation. We don't have information about the mean hemoglobin level or the Rockwell score. Just as a comparison, the Jensen and the STING-2 study included a quite high percentage of patients who were presenting in hemodynamic shock. Also, I would like to mention that in the study by Chan and colleagues, the majority of patients were included with non-active bleeding ulcers, which mean in a Forest 2A situation. And this was also quite different to, for example, the STING study, which included over 60% with active bleeding. I would also like to mention, and this was also discussed in the paper, that due to those patient characteristics, which I just presented, the assumption for the failure rate after standard treatment was maybe a little bit too high. This was, they selected the failure rate of 23% according to a study by Lau et al. But this may have been actually a bit too high, leading to a type 2 error. Again, what are the difference to the other studies? There are also differences in the study design. and the applied treatment. So as you can see here in the Distinct study, for example, we mainly applied standard treatment with clips and injection, whereas in the study by Chan and colleagues, most ulcers were treated with thermal therapy, which is of course fine, but this is just a difference. And another very important difference is that the definition of endpoint was different. As mentioned in the current study, the endpoint was rebleeding at 30 days, and in the Jensen as well as in the Sting study, a combined endpoint of primary hemostasis and rebleeding was selected for analysis. So this is quite important, I think. I would also like to mention that another difference is that in the current study, the rate of primary failure of OTSC therapy was a little bit high with 8%. Just to compare, in the Jensen and as well in the Sting study, the primary hemostasis with OTSC was successful in all cases. And this is important because this affects the results, of course. So in the study by Chan and colleagues, the primary endpoint was analyzed in an intention to treat analysis, which means that all patients which have been randomized are analyzed, including those who had a failed therapy, a failed primary therapy. And just in comparison, if we do a per protocol analysis, which means that we analyze only patients with primary successful OTSC treatment, there is actually a difference in the rebleeding rate from 4 to 18%, which is also statistically significant. So this indicates that primary treatment or the success of primary treatment is quite important. So as a conclusion, I think that despite some limitations, which all have been addressed in the paper, the study is very well conducted and important, and I would like to congratulate the authors to this very nice study. The results are quite surprising, but I think they are not necessarily contradictory to the other RCTs I showed you, because I think the investigated patient population was different in terms of risk of rebleeding. The study, I think, also indicates that the ulcer size alone is not a sufficient selection criteria for OTSC therapy. It is likely that we should also use clinical parameters. And I think the study also demonstrates that the primary success of OTSC hemostasis is very important to minimize risk of rebleeding. I would like to ask some questions to the authors. I would like to ask you, what would be your proposed selection criteria for OTSC therapy? And the second question for me would be, can you please maybe elaborate on the reasons for a primary OTSC failure in your study? Maybe this is due to ulcer location or fibrotic ground or something like that. And the third question I would like to discuss with you is, what do you think, how much training would be required to achieve a high proficiency in OTSC hemostasis? Because as we saw, the primary success is quite important for the patient outcome. Thank you very much, and I'm looking forward to discussion.
Okay, so thank you first of all to Professor Chan for this wonderful presentation, and Professor Chiu, and I really appreciate that it's and I have to tell it to our participants, it's now 2 o'clock in the morning in Hong Kong, and thank you for participating now in this round to discuss your paper. And also a great thank you, Arthur, for your critical comments, for your constructive criticisms. I think it's important in the community to have also a discussion on positive and negative trials. We have now, as you said, you compared 3 papers on the same topic with some maybe different outcomes, but you concluded it is not so a big difference because you tried to explain why you found that OTSC was maybe negative in the trial in Hong Kong. Maybe can I start before we answer this 3 questions by Professor Shannon and Professor Chiu? I would look to ask all of you, is the time point of performing emergency endoscopy, does this play a role? Because I thought in the German trial, and in Germany we do very early emergency endoscopy, we have more active bleeders, and in the Hong Kong trial you had more forest 2 lesions. So does this also maybe influence the outcome, the time point? What are your thoughts?
Well, that's a very good question, Helmut. So actually, according to other studies, we learned that actually we do have time, even in patients which are not which have severe bleeding.
Yeah.
So there was a recent study from Lau and colleagues published in the New England Journal of Medicine, which showed that a very urgent endoscopy did not have any effect on patient outcome. But indeed, in the German studies, we had more active bleedings, which may indeed indicate that we did an earlier endoscopy. I don't know. But it's an interesting question. I cannot answer it fully.
And any comments from Philip or from Shannon? I mean, the Hong Kong is for sure, for those who are participating in this webinar, the center of GI bleedings. The most important papers come from Hong Kong and mainly published in New England Journal or really high-ranked papers. So we really know all your papers in our guidelines, and therefore you have a lot of experience. And the time point, as Arthur said, is essential. But obviously, as you published in New England Journal, has no influence. And I'm wondering now if you change now to another treatment option using Ovesco, does this have an effect? What do you think?
Perhaps I can speak first. So according to Professor James' study, nowadays we do very rarely urgent endoscopy unless the patient is very, very hemodynamic unstable. So I do think it has an effect. So most of our ulcers are only 2A at most. So maybe as Professor Arthur has analyzed, it may be one of the reasons this trial was negative. I would think that the inclusion criteria for a size only, indeed, it's not ideal to choose to the selection criteria for use of OTSC, because these ulcers has very large and fibrotic base. So application of OTSC itself may already be challenging. So it might not be the best selection criteria. And as I mentioned previously, probably a more clinical parameter would be more clinically useful and maybe would help in a positive trial. But at the same time, you're running 2 parallel trials actually at that time. So another trial was the inclusion criteria is a clinical indication of a GBS score for primary hemostasis of OTSC. So we are at Professor James is going to publish that study soon. So that study was also a positive trial. So that study was results is very similar to STING 2 trial. So that is why for this particular study, the selection was also based on Professor James' previous study with a large size. And I guess the reasons for failure in OTSC failure is all the 4 cases were located at a very difficult location. And I guess even with the 20 cases of experience for the endoscopist, sometimes it's difficult to say no to a therapy. So when you see the ulcer, you want to try your best to insert the OTSC. And unfortunately, at some cases, it is not suitable. And the endoscopist only decided it's not suitable after the OTSC application, and usually it's too late. And the application of OTSC, as you all know, would make subsequent hemostasis very, very difficult. So those 4 cases led to a major reason why this trial was negative. So it also, the message is also that the OTSC you must be able to achieve primary hemostasis with the OTSC. If it fails, then you're basically doomed. So training is important, and the criteria of knowing when not to apply OTSC is also important.
Okay, thank you. Thank you.
I wish to just add a little bit of the point that I guess this trial is also interesting that at least we know for large size ulcer, standard therapy can actually work very well as compared to OTSC. So we can go back and actually apply standard therapy for these ulcers, and then we actually, were trained to use standard therapy, which is more easier to apply and less operator dependent. So I think that also have a message that for these ulcer, large size ulcer, I think standard therapy can also help in achieving the hemostasis. And I think the criteria to selection, as mentioned by Shannon, is also important. So we should include more like hemodynamic unstable patient, and probably to select a better selection criteria to include more severely bleeding ulcers, then we should apply the OTSC.
Okay, thank you, Philip. Yeah.
Can I just comment one
Yes, sure.
comment?
Of course, Arthur.
I do totally agree that there are some locations where OTSC application is very difficult, but I think personally in those locations, let's say e.g. the D1, D2 junction, standard therapy is also difficult to apply, right? I mean, so it's not necessarily, in my view, an argument against OTSC therapy, because in those difficult locations, you will also have problems with standard clips and also with thermal therapy, right?
Peter?
So yes, maybe also a little bit for the sake of time, although this discussion is, I think, very interesting. Maybe also for the audience, I think the first question you raised, Arthur, is important. What are the proposed selection criteria for OTSC therapy? Because that's the take-home message, maybe also from these three papers that have been discussed. Shannon, could you first try to answer this question?
So as mentioned, according to other trials and also according to our trial, perhaps a clinical selection criteria of a ROCO score or a high GBS score would be more appropriate for the OTSC therapy. And also in the other OTSC trial that I mentioned was running parallel, the inclusion criteria was a GBS score, so a high GBS score. So both the clinical high scores are actually positive trials, so probably that is the way to go.
Okay.
Arthur, what is your
completely agree.
personal opinion on that?
Yeah, I totally agree. I think we have to add clinical parameters and not only use endoscopic findings. I don't know what is the ideal score or the ideal criterion, but I think a score has the advantage that it is very objective and reproducible. So maybe it's a good way to further investigate that, to do it on a score like the GBS or even the ROCO score.
I mean, maybe a last,
or even an easier score. I don't know.
Peter, if you allow one last question from my side, one stupid question.
Yes, of course.
Patients who are anticoagulated, this are for sure high-risk patients. Shannon, did you have a subgroup analysis in this group of anticoagulated patients to see whether OTSC is more effective compared to standard treatment?
Yes, we did do a subgroup analysis in anticoagulant users, but it was negative. But I guess because the events are so small, a subgroup analysis itself probably is not very meaningful.
Yeah. Okay, thank you.
Well, thank you very much.
We could discuss for sure half an hour longer, but
many hours more.
Peter is a very strict chairman and he wants to take over for the next presentation. And I really apologize to our friends in Hong Kong that you stayed so long in the morning to discuss with us your paper. So thank you and hope to see you soon, and for sure in Dublin to drink a beer with you a Guinness. Okay. See you. Good night. Sleep very well and stay healthy.
Thank you.
Well, I hope you sleep very well the rest of the night, and thank you again. Thank you also from my side for joining this webinar. I think we move on to the next paper, and the next paper will be started. Next paper is from the group of Sydney, from Michael Burke. It's a paper that's published in, or will be published in Endoscopy, the effect of pre-resection biopsy on detection of advanced dysplasia in large polyps undergoing EMR. This paper will be presented by Dr. Michael Ma, but he has the same problem as the Hong Kong group. It's even later in Australia now. So Dr. Michael Ma recorded this presentation, but the discussion afterwards will be done by one of the co-authors, Dr. David Tate.
The effect of pre-resection biopsy on detection of advanced dysplasia in large non-pedunculated colorectal polyps undergoing endoscopic mucosal resection. Endoscopic mucosal resection, or EMR, is an established treatment for large non-pedunculated colorectal polyps. Pre-resection diagnosis guides treatment decisions as EMR is unsuitable for lesions with submucosal invasion. Endoscopic imaging, including lesion morphology and surface pattern assessment, can assess submucosal invasion risk. Pre-resection biopsy of lesions is also used but not established by evidence. In this study, we aim to assess differences in pre-resection biopsy and EMR specimen histology of large non-polypoid colorectal polyps resected by EMR. We also assess the effect of pre-resection biopsy on EMR outcomes. Data was collected and analysed from a prospective observational study of patients referred for EMR of large non-polypoid colorectal polyps from 2013 to 2016 in the Australian colonic EMR study. Exclusions included lesions with prior EMR attempt and incomplete follow-up data. Pre-resection biopsy was determined by review of prior colonoscopy and histology reports. Dysplasia was graded as absent, low-grade, high-grade or cancer. Follow-up data was collected at planned intervals. EMR was performed on 742 large non-polypoid colorectal polyps. Of these, 156 lesions met exclusion criteria, leaving 586 lesions for analysis. Pre-resection biopsy was performed on 343 lesions. Mean patient age was 67.5 years, of which just over 50% were male. Lesions that underwent pre-resection biopsy were larger than those without pre-resection biopsy. A total of 300 lesions were located at or proximal to the hepatic flexure. Rates of pre-resection biopsy proximal and distal to the hepatic flexure were similar. Flat and slightly elevated lesions were more likely to have undergone pre-resection biopsy than lesions with a nodular component. There were no significant differences in rate of pre-resection biopsy for granular, non-granular, or serrated lesions. Median procedural duration for lesions with pre-resection biopsy was 25 minutes versus 20 minutes for lesions without pre-resection biopsy. Submucosal fibrosis occurred more frequently in lesions with pre-resection biopsy than lesions without pre-resection biopsy, but was not significantly associated with the need for more than one modality to complete the resection. Successful EMR was not significantly affected by pre-resection biopsy, with over 97% success in both groups. En bloc resection rates were also not significantly affected by pre-resection biopsy. Overall, intraprocedural bleeding and delayed bleeding post-EMR occurred in 28.2% and 7.8% of cases respectively. Pre-resection biopsy was associated with a higher rate of intraprocedural bleeding during EMR compared with no pre-resection biopsy of 31.5% versus 23.5% respectively. However, pre-resection biopsy was not associated with increased delayed bleeding, deep injury defined as target sinal perforation, delayed perforation, or endoscopically detectable recurrence at surveillance colonoscopy. Paired histology results of pre-resection biopsy and post-EMR specimens were available for 326 patients. Within this patient cohort, pre-resection biopsy found 38 lesions had no dysplasia. These were sessile serrated lesions. 246 lesions had low-grade dysplasia, and 42 lesions had high-grade dysplasia. In comparison, histology of EMR specimens found 31 had no dysplasia, 224 had low-grade dysplasia, and 52 had high-grade dysplasia, and 19 had cancer. With respect to the highest level of dysplasia within the EMR specimen, pre-resection biopsy histology was upstage in 26.1%, downstage in 13.8%, and unchanged in 60.1%. Pre-resection biopsy had sensitivity of 38.7% for no dysplasia, 77.2% for low-grade dysplasia, and only 21.2% for high-grade dysplasia. Specificity of 91.2% for no dysplasia, 28.4% for low-grade dysplasia, and 88.7% for high-grade dysplasia, compared with final EMR histology. This study assessed the effects of pre-resection biopsy on 343 large non-polypoid colorectal polyps removed by EMR. More than half of the 586 lesions studied received pre-resection biopsy. Despite its popularity, our results show that final specimen histology grade differed from pre-resection biopsy histology in over 1 in 3 cases, with the degree of dysplasia being upstaged in the majority of discordant cases. In addition, 19 cases of cancer were found following EMR that were not detected by pre-resection biopsy. Pre-resection biopsy was associated with increased intraprocedural bleeding of 31.5% versus 23.5%, but without significant increase to delayed bleeding, deep injury, or delayed perforation. Lesions with pre-resection biopsy compared with lesions without pre-resection biopsy had more submucosal fibrosis and trended towards longer procedural duration. It is likely that submucosal fibrosis develops following scarring at the site of biopsy, particularly if taken from flat areas. Both intraprocedural bleeding and submucosal fibrosis are known risk factors for early recurrence, failure to perform complete EMR, and need for adjunctive resection methods such as the CAST technique. Therefore, pre-resection biopsy may result in increased risk and complexity of the EMR procedure. Given the shortcomings in diagnostic information and possible hazards from pre-resection biopsy, lesion assessment by non-contact modalities may be preferable. Assessment of lesion morphology and surface pit and vascular pattern using enhanced endoscopic imaging improves identification of submucosal invasion in large non-polypoid colorectal polyps, which typically reside in depressed areas and areas of disruption of pit and vascular patterns. However, most data for endoscopic imaging-based lesion diagnosis come from academic centers and may not accurately reflect the experience of the broader endoscopic community. Adoption of these techniques are also associated with a learning curve and inter-observer variability. Therefore, although image-based diagnosis is preferable, it may not be feasible in all settings and by all endoscopists. As such, we think targeted biopsies can be taken from areas of selected lesions where there is suspicion of significant submucosal invasion, particularly if confirmation will result in a change of management, such as surgical resection. Limitations applied to this study. Firstly, the location of biopsy from the lesion was not specified, although intuitively these would be targeted towards the most morphologically abnormal areas or areas with subtle disruption of pit pattern. We expect submucosal fibrosis to be more prevalent in depressed and flat areas than nodular areas after biopsy, but this has not been subjected to systematic study. Whether the number of biopsies taken affects submucosal fibrosis and procedural outcomes is also unknown. The results from this study were derived from a single referral center and may not be necessarily generalizable to other centers. Finally, given the nature of the study, it was unknown how many lesions assessed by pre-resection biopsy actually had submucosal invasion and thus were not referred for endoscopic mucosal resection. In summary, routine pre-resection biopsy of large non-polypoid colorectal polyps did not reliably detect advanced dysplastic change in this study. Pre-resection biopsy may provide false reassurance regarding absence of submucosal invasion. In addition, pre-resection biopsy is associated with submucosal fibrosis, which may increase EMR complexity. As a result of these factors, pre-resection biopsy should be used with caution in selecting lesions suitable for endoscopic mucosal resection.
Thank you for this presentation. This interesting paper will now be commented by Professor Brian Saunders from the St. Mark's Hospital in London.
So my thanks to Peter and the team at ESGE for asking me to comment on this excellent paper from Michael Burke's group in Sydney, which looks at the utility of pre-resection biopsies on patients with large colorectal polyps referred for endoscopic mucosal resection. These are my disclosures. And what this plays into is the assessment of these large non-polypoid colorectal polyps. When we find one of these lesions, and they're not common, they perhaps only account for 2 to 3% of all polyps that we detect. But when we find one, there's this opportunity not just to prevent cancer, but to treat the lesion in the most minimally invasive way. And the assessment of the lesion is absolutely crucial. We have these tried and tested methods endoscopically and radiologically for looking at the lesion, and it's very important to go through those systematically. And I think it's fair to say there has been a shift towards use of high definition endoscopy and photo documentation rather than relying on biopsy. But what is the place of biopsy prior to these lesions being referred for piecemeal EMR? The key question we're trying to ask is, in the assessment, is the lesion suitable for local, that is, endoscopic excision? And this paper, to briefly summarize, large number of non-polypoid colorectal polyps. Previous biopsy was not particularly accurate in terms of determining the final histology post-EMR, upstaging in 26%, downstaging in 14%, and unchanged in just 60%. And do the biopsies adversely affect the EMR procedure? Well, there was more intraprocedural bleeding if biopsies had been taken previously, and there was evidence of submucosal fibrosis in a higher number where biopsies had been taken. So the conclusion from the study was that pre-resection biopsy really does not reliably detect advanced histology and may even affect the EMR complexity. Similar studies have been done in ESD defects, and again, fibrosis from biopsies has been an issue. I would say the strengths of this study are that it's a very large prospective EMR database. I worked out that in the time period, the group in Sydney probably do around 5 of these large polyps per week, which is a huge workload. And the documentation is very comprehensive. It's prospectively documented with a standardized EMR technique. The question is important clinically. There are some limitations to the study. It is a retrospective analysis at the end of the day, and there are some incomplete data sets, as one would expect. And of course, this is a single tertiary super expert center, so the applicability to the wider endoscopy community has to be questioned. I think my main issue with the study is does it really answer the key question of whether biopsy should be taken at the index colonoscopy? And I'll come on to that a little bit later. Some comments and discussion points. Well, the first thing that struck me was that actually just under half of polyps were not pre-biopsied prior to referral. In my referral practice, almost every polyp, I would say over 90% of polyps, have been biopsied. So there's obviously been some education going on in the Sydney area about limiting biopsies. I wondered a little bit about who reported the polyp biopsies. It mentions that expert histopathologists reported all of the biopsies, but were the biopsies transferred from the referring centre into the expert centre for re-reporting, i.e. was there consistency of histopathology reporting? We know that there is this variation between histopathologists in determining low or high-grade dysplasia and even high-grade dysplasia or cancer. I wondered when these large polyps were encountered, how often did biopsies show cancer leading to surgery before the referral, or before a referral to EMR was even considered. And this is key, because if biopsies actually led to appropriate referral for surgery, avoiding an EMR referral, then obviously they are of benefit. And we don't quite get this from this study, because we don't know the number of patients that weren't referred for EMR. Another comment was, were there high biopsy rates in flat lesions? How many biopsies were taken, and in which types of lesions? That would be interesting to know. And I think the histology upstaging is not surprising because you're looking at the whole EMR specimen after EMR rather than just some small biopsies. But I wondered why there was downstaging. That suggests there might be discrepancies between histopathologists. In terms of the EMR procedure itself, I wondered how many patients had a repeat diagnostic assessment prior to the EMR. Certainly in my EMR practice, particularly with left-sided lesions, I will often do a diagnostic assessment first. Do the Sydney group take these patients directly from the referrer, or is there an intermediate step? I wondered how submucosal fibrosis was defined. This is a key point of the study, but there isn't any mention of how that was defined apart from perhaps the visual changes in the submucosal defect. There was more procedural bleeding in the pre-resection biopsy patients, but not post-EMR bleeding. Of course, post-EMR bleeding is the most significant bleeding. And I just wonder what they think the mechanism for this is and why it affects intraprocedural bleeding, but not post-EMR bleeding. I wondered if perforation and deep mural injury was seen mainly in flat lesions with pre-resection biopsies, then going on to EMR, and whether this is a particular issue that we need to tease out. Biopsying a sessile or polypoid lesion is unlikely to cause significant fibrosis in the submucosal plane, but a flat lesion, we are much deeper on the submucosa when taking the biopsy. I noticed there was a relatively high recurrence rate in this series, and I presume this is because the study time period precluded margin ablation. I'd be interested in a comment on that. And then finally, there was quite a high cancer rate in these patients referred for EMR. Presumably that was not suspected at the index assessment or the assessment which would have been done prior to the EMR. Of course, that doesn't matter too much if all the cancer was very superficial. So I wonder, some more information about what happened to these patients. Did they all go on to need surgery or did they not need surgery? It would be interesting to know that. But an excellent study. And just to summarize, I showed this lesion earlier. As you can see, it's got a 2C component. There's looking with narrowband imaging, we can see some disruption of crypts and abnormal vasculature in the center where there's an area of demarcation. And this lesion non-lifts. In this case, I did take biopsies, which interestingly did show cancer. And the patient went on to have surgery and had a T1SM3N1 cancer. So I think biopsies, particularly in areas of suspected cancer, are still indicated, but possibly the summary is to biopsy just very prudently and not in flat lesions if you don't suspect cancer. Very much looking forward to the discussion in due course. Thank you.
Well, I think this is also a great paper for the discussion, and I'd like to thank Michael and Ma for a great presentation. Of course, I'm also very happy that Brian Saunders is on board. I consider him one of the world-leading experts in EMR, and I think his questions are very important to discuss. We also have David Tate on board, and he may start answering the questions that have been raised. So my suggestion is, Brian, that you raise the question again, and that then David can try to answer them, or at least give some explanation on the related to the question that is raised.
Okay, that's great. So my first question there is looking at the histological assessment. And I wondered, have you actually had an education process with your referring endoscopists regarding not biopsying? Because actually 41.5% of polyps were not pre-biopsied. Is that something that you've actively pursued?
Thanks very much for the opportunity, and thanks for the questions. Really insightful questions into this study, which I'll do my best to answer. Indeed, there has been an education program. The study period was a couple of years before 2016. So at that time, that education program was ongoing. I'm interested, Brian, that you say that in your practice, most polyps have been biopsied. That's definitely not the case in my non-Australian Belgian referral practice, where probably this number actually seems relatively similar to what we are seeing. So yes, there has been an education program. Yes, we in Sydney had been systematically reaching out to referrers, doing a symposium every year in Sydney for that purpose. So perhaps that does have something to do with it. For me, it's
I think it's an important point, because obviously the message needs to go to the people who are finding the lesions and then referring them. So we'll move on. Who reported the polyp biopsies? You mentioned they were done by expert histopathologists, but did you take the report from the referring hospital, or were the biopsies transferred to Sydney, where they were re-reported by one of your histopathologists?
So no, indeed, the polyp biopsies were reported by the histopathologists in the referring centres. Yes, the EMR specimens were reported by experts, but indeed that is not included in the methods section, and is a very good point, and probably does come to some of your later questions. Why there were some other discrepancies, probably because the reporting histopathologists were different between the study centre and the other centres.
And do you get any feeling for, I mean, this study was not about this, but one of the key questions regarding whether you do take biopsies or not is, do we know how many potential referrers were sent for surgery appropriately by biopsies being taken?
No, we absolutely don't know that. And that is a huge unknown of this study. We don't know what happened before they got in the door of Sydney. So this is a prospective series of what happened in that referral centre, that indeed, as you pointed out, one referral centre in Sydney, and what happened before then, and the utility of biopsy in that situation is unknown from this study. And you have very nicely shown how you might use biopsy to good effect. If you have a demarcation zone, you should direct it for sure at that suspicious area. And this study simply is unable from the data to comment on that.
Yeah. The histology upstaging, not unsurprising, because you've got a bigger thing to look at for your histopathologist to examine. But why downsstaging?
Well, I think you're right. I think you answered it in your presentation for sure, that it's about the histopathologist. And so, I mean, we see it in all aspects, don't we, of resection. We see it in Barrett's esophagus. We see it, I think, here, that inflammation is often misinterpreted for degrees of dysplasia, and it's simply the inter-observer. I mean, it's difficult, isn't it? You show 10 histopathologists what we as the endoscopists think of high-grade dysplasia as the gold standard, and do they all come out with high-grade dysplasia? Almost certainly not. So in my view,
there's a lot of data looking at histopathology reporting in colitis dysplasia, for instance, and the kappa is very poor actually between different histopathologists. So I think that is an issue even on sporadic tissue. Okay, and now the flat lesions in particular is concerning if they're biopsied. Did you know the number of? Did you have situations where multiple biopsies were taken, or you don't know the numbers exactly?
So we don't know the number of biopsies taken prior. No, that wasn't included in the study. In fact, we started to look into that, and as you might expect, the reporting of that, we looked into the pathology reports. It wasn't very often documented the number of biopsies present. We looked into the referrers' endoscopy reports, and it was, I mean, I don't know how many people watching here report the number of biopsies they take of a polyp. Maybe some, but certainly not the majority. And it just wasn't realistic to look into that. So no, we don't know that.
Because I think over biopsying is clearly a mistake. And is going to cause quite a lot of injury to the submucosa. But moving on to the EMR procedure, because I'm aware of time. How many patients had a repeat? I mean, obviously, but prior to actually performing the EMR, you're going to do another assessment, another visual assessment, but you've still got a 5.8% cancer rate, despite that. And were those cancers very superficial and didn't actually need surgery, or?
Lots of questions in there. Can I just quickly go back to the one you asked about flat lesions, and I didn't mention anything about that. I mean, the only thing we know about the lesions in this study was the whether they had a 1S component or not. And interestingly, those biopsied, you were more likely to have a biopsy if you had a big 1S component, which is a bit strange. I mean, kind of against what you might expect. I guess the cancers were probably excluded because people biopsied a cancer and then it never came to the study center. So maybe that explains why. But people are obviously, when they see a big bulky thing, they want to take a biopsy of it. I mean, that's the message coming out of that. Why is not particularly clear to me. Maybe that they think that's going to help. And of course, it's less likely to help if it has a big nodule.
But the big nodule is where the cancer is likely to be.
But of course, yeah, no, not going to be accessible by biopsy, probably.
No,
I guess.
no.
Yeah. And to your question about the way that it works in the Sydney Centre, so indeed there is no reassessment. So the patients often, the thing about Australia, of course, is that the distances are huge. So patients, they often don't want to come. Often the patient wants surgery rather than endoscopic resection because they have to travel such a long way to get it, right? So when they come, they expect a one-stop shop. And what that means is definitely they don't get a reassessment often before they have their procedure. And I mean, does that change the 5.8%? I mean, I personally think the 5.8% is all right if you including in that en bloc EMR and, like you say, superficial cancers. This data is not in this paper. It's certainly available and could be looked at. But no, patients were not getting a routine diagnostic assessment prior to their EMR.
I think even with all of our advanced imaging techniques, it's still very difficult sometimes to accurately pick up cancer.
And big nodules and buried cancer as well. I think all those things go into that discussion.
Yeah. What about the submucosal fibrosis? There are scores for submucosal fibrosis. Was that just a visual thing, looking at the pictures of the?
Yeah, I think so. So it's not looking at pictures. It's the endoscopist's opinion at the time. Yeah. We are kind of we were fans at the time of the F0, F1, F2 Japanese score, but basically that's binary, isn't it? F1 and F2 describing some submucosal fibrosis and F0 describing none. And so in this case, F1 or F2 was called submucosal fibrosis and F0 was no submucosal fibrosis. So indeed, the opinion of the endoscopist on the submucosal plane at the time of endoscopy.
Intraprocedural bleeding more common when you've got that fibrosis, when the biopsies have taken, but no detrimental effect to post EMR bleeding, or in fact completing the EMR or successful outcome. What do you think is the mechanism there? What's happening? Why do you get more intraprocedural bleeding?
I think that's a great question. I mean, presumably you cause inflammation by biopsy and healing, you cause neovascularization, angiogenesis. That's the reason you can explain, I think, therefore, why you have more blood vessels at that point and why you might get submucosal fibrosis and why you might get more bleeding. Why don't you get more post-EMR bleeding? Well, if you look at the numbers, there were, what is it, in the non-biopsy arm, 9.1%, in the so that's what, it's 46 patients in total in the study who had delayed bleeding. So is it powered to detect a difference? Almost certainly not. And maybe there is a small difference, but certainly with these numbers, maybe we don't tease it out. Is that maybe the reason why? We also,
possibly. Well, and I wonder whether the fibrosis from the biopsies means that when you're snaring the lesion, the path of the snare is that much deeper on the submucosal plane, so you hit larger, you're more likely to hit a larger vessel. But you would think then you'd have a higher risk of post EMR bleeding, but perhaps, as you say, it's not powered sufficiently to see that.
That's actually very interesting, because of course you're absolutely right. You do often get a step, don't you, in the submucosal fibrosis bit where you make a deeper excision. But maybe actually, I mean, we kind of know, don't we, with EMR, that the mechanism of post EMR bleeding is that you don't have a deep stomach, like in your EMR specimen, you may be at the SM1 type level, you're not at the ESD on the muscle level. And so in ESD, you deal with all the bleeding during the procedure. In EMR, those vessels sit there injured and maybe ulcerate later. So maybe indeed that is the reason why you're not getting more bleeding, even despite the fact that there's more blood vessels here.
There's a very beautiful picture in the paper which shows the deeper submucosal fibrosis.
That's true.
One of the resections, which I would draw people to. I mean, just finally, were the deep mural injuries and the perforations more frequent in the flat lesions with pre-resection biopsy? I presume that was the case.
I don't know the answer to that. From the data presented in the paper, we can't see that. We certainly could go back and look at subgroups of that, but this wasn't investigated here, no.
Well, look, all in all, I think an excellent study, and again, using the power of this very large prospectively collected database to answer, or at least, you know, draw some conclusions from very important clinical questions. So thank you very much for the data and for the paper. Absolutely fantastic. Thank you.
Well, I can only echo you. I think, Brian. I think this was an excellent paper, and I think also an excellent discussion. It was fascinating to listen to two experts doing nothing more than in their lives than doing everyday EMRs in large numbers. So, really, thank you very much for joining tonight.
Maybe Peter, may I ask a final question as well?
Of course.
I mean, the take-home message for our participants is obviously, for me at least, maybe for the others as well, biopsies are not necessary, right? And we have a position. Come on, no, I'm not at the end is my comment. In our position statement on green endoscopy, we also strengthen the topic that we can avoid waste by taking unnecessary biopsies. So we save CO2 footprint, we save biopsies, and so on, so the biopsy forceps. So is there, Brian, you showed in your case a lesion where you took a biopsy. Actually, I also would take this biopsy because this is a case where I think surgery or even radiochemotherapy in the rectum is necessary. And our radio-oncologists never would do a radiochemotherapy without proven biopsy cancer. So the question is, when should we biopsy? Is there still a need? If you go for surgery, is it necessary or just leave it? That's the question to both of you.
I think the only indication for biopsying these lesions is when you have a high index of suspicion for deep submucosal invasion. If you think there's superficial invasion, you probably shouldn't biopsy. Mm-hmm. But we're then at a very difficult sort of level. It's tricky to be able to accurately predict that. We have the JNet classification, which is the nearest thing, using magnification. But if you think there's deep submucosal invasion, then biopsies, I think, are important, not just for what you said, but because basically our surgeons would hesitate to operate if they haven't got a cancer histological diagnosis.
And I think although the patient accepts the indication for surgery more, if you tell him we have a proven cancer now and we expect it's very deep submucosal infiltrated and you have a risk of lymph node metastasis. This is the same. I'm completely in line with your comment. But
there's a concern with flat lesions. I think there's a reflex to simply biopsy them because we know that they have statistically a slightly higher risk of containing a tiny focus of submucosally invasive cancer, and that's where the mistake is. Because then you scar the submucosa, you make ESD more difficult. You make all more difficult.
You mentioned.
So that means that the take-home message is that you should be very restrictive with taking biopsies, but definitely there's a place for taking biopsies in selected cases.
Yeah, I would agree with that.
Well,
David,
thank you.
David, you agree with our?
Well, I think that the most important thing for us to think about is that most people out there, maybe they don't have the experience of Brian, of the Sydney group or myself, when they're looking at these things, and if they're going to take it, like maybe you're in Australia, maybe you're 500 miles away from the most center, maybe you don't have an MDT, and in those situations, you should biopsy a zone of suspicion. You shouldn't just randomly biopsy a lesion, but there probably is a place for biopsy, and it's in detecting cancer.
Okay, thank you.
Well, I think we're all in agreement. So thank you very much again for this fantastic discussion presentation. I think we go to the final slides. And that's of course that don't forget to register for ESGE Days 2023. Early bird registration ends by the end of February, and of course next slide please. Don't forget to consider becoming a member of ESGE. I mean there are many advantages of of becoming a member, and not in the least going to the ESGE days. And of course, we will have again webinars this year. And the next one will be in 2 weeks' time, and that's about the management of benign and malignant esophageal strictures. Thank you very much for joining tonight, and thank you very much for participating again next or in 2 weeks' time. Enjoy your evening, and bye-bye.
See you in 2 weeks. See you, Peter.
See you, Helmut.